Welcome to the Advaita Health Podcast, where we bring together voices from the front lines of care, the science of flourishing, and the systems shaping society. Each week, we explore clinical practice and medical innovation, dive into the daily habits that support well-being, and examine policies and technologies changing healthcare. This is the Advaita Health Podcast, conversations at the intersection of medicine, mindfulness, and meaning. Let's dive in. All right, I am really excited to sit down with Dr. Book today. Dr. Dewayne Book is the Chief Medical Officer at Advaita Integrated Medicine. His storied career in addiction treatment and psychiatry began in 1987 as an alcohol and drug counselor. He then went to complete his master's in social work and became a social worker in 1992, and then went back for even more school and graduated as a medical doctor in 1996. He then began his career working in residential treatment and leading Duke's psychiatry residency program for addiction treatment from 2000 to 2009. After that, he worked in outpatient settings from 2012 to 2018, and then moved to Raleigh, where I had the pleasure of meeting him, where he worked in an outpatient setting 2018 to 2022. Dr. Book joined our team in 2022, and after a year, he was our medical director, and after another year, he became our chief medical officer. So there are very few people in North Carolina who have the breadth and depth of experience in substance use treatment as Dr. Book, and I am thrilled to sit down with him today. Dr. Book, welcome to the pod.
Thanks, Tripp. I'm glad to be here. Hearing you run through those dates and years like that, it seems like yesterday that the whole story started. But yeah, it's been an interesting journey for me. I think that when I was thinking about talking about in my career and when it began, and I probably should tell you that I've been doing family therapy since I was 4. So that family therapy work I didn't go very well. But I went to LSU and got a undergraduate degree in psychology and graduated there in 85. But I had been a pre-med major. Because of my own addiction, I didn't perform very well in school, as anyone who has a history of addiction might know. I then was frantic to find a job. I had a degree in psychology, and my electives were biochemistry and comparative anatomy. And I applied for a civil service job, is what they used to call it, and started getting these interviews for probation officers and all sorts of things. And then I got an invitation to be a substance abuse counselor at a small clinic in Louisiana, Natchitoches, Louisiana. And most people know this place, although they aren't aware that they do. It's where the movie film Still Magnolias was filmed. Down. So here I am. I have a bachelor's in psychology and about 10 months of sobriety. And those are my qualifications. And they gave me an office and then just started throwing people at me. And
that sounds like how a lot of addiction treatment is still done today. Some places.
Some places, I think it was a lot more Old West sort of ideals back then. They were happy to have someone in the office that they could say was treating addiction. It was a state clinic, and not a lot of energy around the treatment, but not me. I was on fire to figure this out. And I think about now how I practice, medicine and psychiatry and clinical care, that it really did begin there because I went in to that room with patients and really didn't have enough knowledge, and I didn't have clinical skill. I had very sort of superficial knowledge about addiction recovery. So the only thing I had to bring into that room was myself. And so that really was the seed of my whole practice of medicine, that I bring myself into the room, and it's the relationship with the patient that is really, I think, paramount more than the skill or the medicine or all the other tools that we have, I think the relationship with the patient is the most important. And that was all I had. So that's, of course, where I started.
What made you go back and for a master's in social work? Why weren't you just a counselor forever?
Well, I felt like I just didn't know enough to do what I was being asked to do. And, even though I didn't have like a lot of clinical skill or training or any of that stuff, I knew that I wanted to be good at it for the patient, that I felt like it was a huge responsibility and that I was obligated because of that responsibility to be the best that I could possibly be. And even before the MSW program, I got a license, or back then it was a certification in counseling, and you go all these trainings and stuff. There was a group of social workers in that little town, and they got together for support and would do case conferences. And even though I wasn't a social worker, they let me join that group. And so, and then at the time, to me, like, social workers were like the epitome of all that you could possibly be. And so, the university took me out of that job after a year and a half at the hands of the governor, who laid off a third of the state employees. And then I went for another year and a half and worked for a for-profit corporation. And that was a huge wake-up call. It had never occurred to me that doing this work could be anything but service work. And so that was my introduction into the world of corporate medicine. After a year and a half, someone embezzled money at the company and they laid off a third of the state employees. And so, I just think the universe said, I've got a better ideal for you. And it kept sort of narrowing the path to me. And so it became clear I had to have more education so that I could have better job security and, know more about what I was doing. And so I went to, got a master's in social work. During the time I was getting the MSW, I also was the clinical director of the IOP program at Athens Regional Medical Center as I was doing that. So
it's fascinating to me, even today, where I think people have a lot more credentials. I'm still amazed that we have people who are CADCs and maybe clinical directors or chief clinical officers at some programs, and I guess and that hasn't changed either. So
right.
why'd you go back? You thought social workers were the epitome of the human services field, and yet you decided to go to medical school.
Well, I mean, that came from realizing that I didn't know enough to do what I was being asked to do. Partially. The biggest piece there was that I didn't have access to medication as a tool. And the social work program was 2 years, the one I went to, and it was very good for social work, but it wasn't able to really touch on a lot of the neurobiology or the medical science behind that. Also, I think that part of the reason I went to med school was I wanted power.
Yeah.
Because I'll just be frank with you, that in a team meeting, even though I felt as a social worker or even as a counselor, I more intimately knew the patient, whoever the physician was the only person who could really make the decision. And sometimes, I don't know, naive or arrogant or something, I felt like I knew better what the patient. Well, just because I knew the patient, I had a relationship with the patient. And it was frustrating to me that without the MD after my name, that I sort of didn't carry as much weight in my assessment. And that's probably not true in all settings. I believe it's certainly not true here at AIM, that everyone's input is valuable. So that was part of it. And just wanting to be better at my job.
And so I've heard this story a few times, but so you graduate from medical school, and then you end up in North Carolina, moving to the big cities.
Yeah, well, I went to, we had moved to Georgia from
Mm-hmm.
Louisiana to get an MSW. And then after my MSW program, I took like an overload of biochemistry courses to see if, I'm clean and abstinent now. And it's a little frightening to go back to school because I think I'm really smart, but I was addicted and that's why I did poorly. And it's a little frightening to find out maybe that's not it. But it turns out if you go to class, that it's not that hard. And so I took an overload of graduate level biochemistry courses while I was in the MSW just to see if I was able to academically perform. And I was. So then I applied to med school, but I had, of all things, lost my citizenship to the state of Louisiana. As if that would be something they would take from a person. But so then I wound up going to med school in Georgia, and I went to Mercer
Uh-huh.
Medical School, which was a great experience. It was a problem-based learning school, and I was an older student, but I actually was the average, the median age of all the students there. Pretty small. We had 40 people in our class, and it was fantastic. I had a great experience there. And then I think I only got into 2 med schools, although I applied to 12. The LSU GPA was not impressive, but then when I finished med school, I'd done very well in med school, and then getting an internship in a residency turned out to be a lot easier. I had lots of options, and sort of decided to come to North Carolina. My wife at the time had just finished a PhD in education, and so there's a lot of job opportunities for her here. And Duke seemed like a very impressive name, particularly to some kid from Louisiana. And so that's how I got to North Carolina, and I've been in North Carolina since '96.
So tell me a little bit about, I know the story, but I'd like for all the listeners to hear what it was like to go from being a resident at Duke to all of a sudden being in charge of residential treatment. Give us some good stories.
I'll tell you the most interesting story about this, that I had been sober about 8 years, and then on the move in the U-Haul to Duke, almost had a relapse, came very, very close to a relapse. And, moving is a very dangerous time for people in recovery because you're changing your support network. So I had almost had this relapse in Columbia, South Carolina, at my sister-in-law's house. And then, when I got to Durham, I parked the U-Haul and went to an AA meeting immediately. And when they said at the meeting, does anybody have a burning desire? I said, my name is Dewayne. I'm an alcoholic. I almost relapsed 4 hours ago. I need a sponsor right now. And this guy came up to me, and after the meeting, he said, I'll be your sponsor. And he turned out to be a retired counselor from Fellowship Hall.
Wow.
Which I hadn't, I thought it was a Baptist parsonry or something. It seemed like where you have, I didn't know. It seemed like, and then after I got my medical license after internship, Jesse said, I really want you to try to apply to Fellowship Hall. And I was like, I don't really know what that is. And he came over to my house one day and demanded that I fax my resume to them. And when they got the resume, on paper, I look pretty good, right? I've been a counselor, and I've been a social worker, and now I'm a Duke resident and physician. And so in my second year after I had a medical license, I began to moonlight at Fellowship Hall, and I would go up every Saturday and do psych evals on the patients there. And unbeknownst to me, at the time, it actually was a 3-year job interview. And so when I graduated residency, they offered me that position. I knew it was what I wanted to do. I wasn't convinced that I knew enough to do it. But it was a huge step, that it was, I left residency the same way I left medical school, the same way I left MSW, believing that I just didn't know enough to do what I was wanting to do. And I still feel that way. And I do a lot of outside reading. There's so much to know. I think the thing about education is the more that you learn, the more you realize how little you know. And so, I mean, I think that's how I got to fellowship hall. And I certainly loved my time there. Although at the time I was the youngest man in the hospital, and there were 30 patients and 80 staff members, and it was a very big growth experience there.
I bet.
But doing everyone's medical care and their psychiatric care and their addiction medicine care sort of single-handedly. But I think one of the other things that I did there that I am very proud of is that at the senior year of our residency, right before that, the faculty at Duke brought all of us together, all my class, and said, everybody, every year, all psychiatrists in residency take an in-house training exam, and every year, all across the country. And so Duke faculty brought us all in and said, your class has done the best in the substance use disorder section of this test than any class we've ever had. We want to know what we did right with you so we can repeat it. And, my classmates were like, no, it was him. It was Dewayne. Dewayne told us what to do and not to do, and all about addiction. And so as a senior elective, I got a chance to rewrite a Duke University psychiatry department substance abuse curriculum. And we required a certain number of hours of patient contact. And we had an outpatient site. And after a year, that site said they no longer wanted residents there. And so it created this absolute need that the residents had to have a practice location. And so through a lot of work and charm and, I don't know, maybe manipulation, I created a residency training track at Fellowship Hall, which was not an elective, but a requirement. And that was 2001. And 24 years later, it is still in existence. And every psychiatrist who's graduated from Duke since then has had a month of addiction-focused treatment. So I think at the end of the story, that's probably going to be one of the most impactful things that I did or was part of. And I had, the residency training director there was very helpful with that. And it was great. And now everywhere I go, I meet residents who I was there attending. So something about that feels good to me.
Yeah, it was really cool to meet Dr. Spessett. And one of the first things she said was, Dr. Book trained me when I was a resident. And so now we even have folks you've trained on our team. Yeah. One of the other stories I'd love to hear a little about is, working with Fellowship Hall. And I think you worked with the board at the time to approve the use of certain medications during detox.
So this is it's a really important, topic to talk about. That addiction treatment has never been the focus of much research, and even in the beginning of my career, the stigma of having addiction or substance use disorder was even worse then. Even though addiction and alcoholism was first classified as an illness by Benjamin Rush, who was one of the original signers of the Constitution of the United States. So it's not a new concept at all. But because of that, there's not a lot of research, and we rarely get new tools to treat this addiction. A 12-step program sort of, that concept began in 1935. And out of that, in the early 1970s, people began to develop treatment centers that were really based on that philosophy. It was sort of the only tool there was at the time. And so, the adage that if all you have is a hammer, everything must be a nail. And so if you came in to any treatment center during the 70s and 80s, that was the medicine you got. You got referral to 12 steps and pretty much it. A lot of the treatment facilities at the time was opposed to any medication intervention for any psychiatric symptoms. But they were, we all were quick to use benzodiazepines to prevent alcohol withdrawal, seizure in a patient going into DTs. So when buprenorphine for opiate addiction came onto the scene, I knew it was a tool that I wanted to take advantage of because, here was finally a tool. And we have so few tools in addiction medicine that I wanted us to use it because we want people to stay alive and we want people to not suffer. And so it was, a challenge to do that. It was a new concept, and there was a lot of people had very negative opinions about it without really knowing much about it. And I, in preparation to present this, I did a study of a retroactive study of the patients who left AMA. And the highest AMA rates were among patients during the first 10 days who were in opiate withdrawal. So if I can take this graph and this data and saying the alcoholics are not leaving during detox because they're getting medication to alleviate their suffering. And so now we need to use this medication to alleviate the suffering of people in opiate withdrawal. We can keep them in treatment longer. And essentially, it also made my job easier because people who are addicted to opiates and opiate withdrawal, I met with them every day to talk them into staying 24 more hours. Because, they start to look out the window and they get this faraway look in their eye and they're like, oh, they're going to be leaving AMA within 48 hours. We got to really pull the troops around this guy to keep him in. And so I started using buprenorphine there for detox, and our AMA rates fell dramatically for people in opiate withdrawal.
So just speaking of buprenorphine and medication-assisted treatment, tell me how that's kind of changed over the years. In the past 38 years, you've seen a lot of patients. I don't even know what was around 38 years ago when your counselor days were there. But, tell me about naltrexone, buprenorphine, and kind of how you've seen the evolution.
Well, I think back in the 80s, when I was a counselor, that methadone was available. Being on methadone is super cumbersome. You have to go every single day, and it's saved many people's lives. It's not as innovative as buprenorphine is, and so buprenorphine is sort of the next step into that. People get very opposed to any sort of medication like that. And I think getting it more accepted into the addiction medicine field, and, historically, not so much now, but historically, most of the people in addiction medicine were people like myself who had a personal history of being struggling with addiction. And they have very tight ideals. This is how I did it, and this is how it must be done. But the thing is that, I think that there was not a lot of urgency to develop, appropriate medications for opiate addicts because you do not die in opiate withdrawal. The number of people who have died in opiate withdrawal in the history of mankind is zero. The number of people in opiate withdrawal who want to die is 100% because it's absolutely miserable. So the buprenorphine helps with that, and the way that I use it and have used it since I started using it outpatient is part of a comprehensive program. And of course, there are Suboxone clinics, I suppose, where that's all they do. But the medication should legitimately be used as a comprehensive program with therapy and external support networks and addressing other issues as they come up. And so how I use it is I give it a week at a time when you start. And, if you made your therapy and your counselor's appointment and your drug screen is clean from all other addictive medicine, then, we'll do another week. And then after a while, we do 2 weeks, and then we do a month. I try to keep patients on it from 9 to 18 months and gradually taper it every 2 months. The ideal being that if this is the human, this is the person with addiction, and this is their addiction, that the sort of Suboxone or buprenorphine sort of separates this and from your addiction. And so now you've got some time, and your cravings are low, your discomfort level is low, and you've got some time to put some other things between your addiction and the medication or your disease from your recovery. And so you can like build external networks or resolve some of the issues that make sobriety more difficult. And as the medication dose gets lower, your recovery skill gets higher. So that by the time that people are finally step off of Suboxone, then they are buprenorphine, then they've got some recovery skill under their belt, and most of them are ready to be off of that. And then we'll move a patient into naltrexone. Naltrexone is a medication that they call it an anti-craving medication. In reality, it makes use less reinforcing in the brain. It's very effective for people with opiate addiction. It's also very effective for a subset of patients whose alcoholism is mediated by the mu receptor in the brain, which is the opioid receptor. There's a group of, and those patients are generally comorbidly addicted to alcohol and opiates. There's another group of alcoholics who are addicted primarily to alcohol and benzodiazepines, and this is a GABA mediated illness, and those people do not respond as well to naltrexone.
Do you ever use Antabuse in your practice these days, or when's the last time you prescribed Antabuse?
About an hour before we started. So yeah, I got like I use every tool that I mean, my relationship with the patient is a tool, the group is a tool, and aftercare is a tool, and, Dharma recovery or smart recovery or a 12-step program is a tool. And every medication that I have in my toolbox, I'm going to use because my goal is to keep this person alive. And I think that, addiction kills 8 out of 10 people who have it. And if you come to me and I'm your physician and I say, Tripp, you have leukemia, and it's a horrible form of leukemia, 8 out of 10 people who die from it, who have it, die from it. And I've got these tools in my toolbox, and I'm going to use every single one of them to try to keep you alive. It would be absurd for me not to use every chemotherapy for leukemia that I had availability, particularly when the mortality rate is 8 out of 10. And so, of course, I'm going to use every tool. And then the patient also is like, I was like, the people who live or the people who take the red pill and the blue pill, and the patient's like, I'm just going to have the red pill, doc. It's like, based on what? So yeah, I use Antabuse. Antabuse is a medication that was developed in the 50s accidentally, and there was a rubber factory, and all the people who worked in the factory, when they go to the bar after work and try to get drunk, they got sick. And so it was a byproduct of that production of a rubber that was turned into a medication. One of the very first medications for alcoholics was disulfiram of Antabuse. And the way it works, it blocks an enzyme in your body, and the metabolism of alcohol causes the acetaldehyde to accumulate, which is a toxic substance. Sounds like formaldehyde. It's a cousin. And it gives you a horrible headache and sweaty and stomach cramps and backaches. And so, but you have to take it, right? And once you take it, you're good for about 72 hours. But people who have addiction, their addiction is very, very powerful and cunning, and it can trick them into skipping it for a couple of days or forgetting it.
I love, there was a study for community reinforcement approach, and the, spouse of the individual in treatment was withholding sex unless they took their Antabuse. That's how they ensured medication compliance. And they had like phenomenal results, which helped kind of pioneer like the community reinforcement approach.
Well, I guess I mean, that's what we're talking about. We're talking using all tools, and if sex is a tool, then
Totally.
so be it. Like if it, so I use antabuse. I encourage my patients to take it, at least for the first month. So we
Mm-hmm.
give the brain a chance to heal. Most professional programs, like the North Carolina Physicians Health Program, or impaired dentist, or pharmacists, nurses, require that you take it for a year or two. It's effective if you take it. And then I have patients who I just want them to have it in their purse or their glove compartment, so that if you get in a high risk situation, they can take it.
Mm-hmm.
It doesn't, it's not dangerous. It should make you sick and give you a headache and vomit. And I had an alcoholic who said, "Well, that just sounds like a Tuesday to me." so, uh, so there's another medication that a camprosate that is a medication for that really is the only medication that addresses the post-acute withdrawal syndrome in the
Mm.
brain, and it speeds up the correction of that, which is an 18-month process. And it's a cumbersome medication to take. So these are the negative, 3 times a day. But it's a fantastic medication for the patient to take, because 3 times a day, they're swallowing this pill to help them stay sober. And they're making another commitment 3 times a day to stay abstinent. And so I think
Mm-hmm.
symbolically, it's a wonderful connection to their commitment to remain abstinent.
What do you think has changed them in terms of patients? Have you seen major changes at any point during your career in terms of comorbidities, or if we use the term drug of choice, how's that changed
Have
over
I
the
mean,
last few decades?
I talk about this when I do the neurobiology lecture to the patient, that the percentage of patients in the United States who are addicted is 18%. And that number has remained very, very consistent throughout decades. The drug of choice changes. Uh, Now, the drug of choice is really determined not by someone's preference or personality, but it's actually neurochemically determined. For example, I have patients who present to me, and their drug of choice is cocaine, and they tried opiates, but they didn't like it. Or they tried a benzo and they didn't like it. They tried, cannabis, they didn't like it, but they loved the opiates and the amphetamines. And so they're saying to me, Dr. Book, the deficiency in my brain is dopamine. And these people, and then the other people who hate cocaine, right, who hate amphetamines, and they're saying my dopamine levels are fine, my deficiency is this. And so when patients are telling you their drug of choice, they're really disclosing to you their brain chemistry. Uh,
Mm-hmm.
so in the 80s, everybody was addicted to crack cocaine. Every person who came into the clinic, their drug of choice was crack cocaine. I remember I'd been at work about 9 months, and a patient who came and was addicted to heroin. And it was just like, I'd never seen that. No one in the clinic had ever seen anybody addicted to an opiate like that. It was very rare. Everybody was addicted to crack. And then the crack epidemic sort of subsided some, and it was replaced by the crystal methamphetamine. And then that was the next devastating drug that killed so many people and just devastated so many lives. And then we could do a 19-hour podcast about this one, but next came the opioid addiction. And I think there's been some improvement in that. It's still a major struggle. And now we're getting more and more into the cannabis epidemic.
Mm-hmm.
And
Yeah, I
people,
think that's going to be really interesting, especially the kind of emerging evidence on the rates of psychosis in young adults or adolescents that are using the high potency THC products. What about like the co-occurring kind of psychiatric diagnoses? Is this I hear a lot, and I feel like the narrative I hear is, patients are more complex. They're not showing up with alcoholism, with drug addiction. They're showing up with polysubstance use and ADHD and bipolar. Or do you think we're just diagnosing that more, or how do you feel like that's changed over time?
well, the people don't change, right? But the more you know, the more you realize how little you know. And so, I mean, we're sort of at a stage in substance use treatment and in mental health that we know more. And so we're able to see more and we're able to name things more. But the diagnosis, the incidence of diagnosis of some disorders have increased, but I don't really believe that there are more of those disorders. I just think we're recognizing them more. It's really difficult with people with addiction because early on they sort of meet criteria for every psychiatric disorder in the DSM-5. Right? They've got every symptom of everything. There's a concept in medicine called parsimony, and parsimony is the fewest diagnoses to explain the most symptoms, right? When I see a patient, just a psychiatric patient, and they have 8 psychiatric disorders and none of them are addiction, I think there may be addiction in this patient, right? Because, post-traumatic stress disorder, generalized anxiety, panic disorder, schizoaffective disorder, attention deficit disorder, idiopathic insomnia. Well, just the universe is just not that cruel. No one's going to get to have every diagnosis, And then sometimes in the DSM-5 says, unless these symptoms can be better explained by substance use disorder or medical disorder. And so if you instead, do an assessment for substance use disorder, a lot of these diagnoses fall away. Early abstinence, yes, you are very depressed. You have very high anxiety and you have panic and you have insomnia and you have attention deficit and all those things because the brain doesn't have the neurochemistry that it needs to function early in, and it doesn't doesn't correct itself in 7 days. Right? It's an 18-month process for everybody. So you want to sort of, if you can, wait until the patient has some abstinence before you start making diagnoses, and they all should be provisional now. But in the early part, a patient will early in recovery maybe come to me and say, that they're severely depressed and they meet certainly all their criteria for it and all the rating scales and the assessments indicate that they have a major depressive disorder. I know that it is probably post-acute withdrawal, but I will treat it anyway because it conveys to the patient in that sacred relationship that I hear you and I believe you and I have compassion for your suffering and I want to try to help you. I did it with a caveat that this medication is probably not going to be very effective because the brain substrate that is needed isn't available, right? You think of for example, fluoxetine or Prozac, which is a serotonin reuptake inhibitor. Well, you swallow the pill, it goes to your brain and it says, I'm here to inhibit the serotonin. Where's all the serotonin? There's not any because the addiction has depleted it. And so, I don't know if I'm answering your question completely. I think that we know more about comorbidities. One of the interesting studies that I did, just not a published study, but just sort of in-house study that for 8 years, I had every patient in a 30-day inpatient treatment facility take a Beck depression inventory every week. And so, of course, when you come in day one, 99% of the patients are severely depressed. The other 1% are either lying or not paying attention. It's rehab. Things aren't going well, right? So, but if you track that every week, the Beck depression inventory scores fall. And by the 4th week, the percentage of comorbid of major depression in this population is lower than the average population. Not the normal population, but the average population. And there's a group of people who, despite abstinent, their Beck depression inventory scores remain elevated, and that is comorbid major depression. Separate. The other one, the slanting line down, is substance-induced mood disorder. This is a comorbid major depression. And then there's a group of people whose symptoms worsen as they become abstinent, and that's a patient who likely has post-traumatic stress disorder.
Oh, interesting. I didn't know that. One of the things I've heard you explain to our team before. I think particularly when you've had folks who hear about TMS or transcranial magnetic stimulation and they say, oh my gosh, I really want this. And then I think, everyone's supposed to screen for substance use before getting authorization for TMS. I'm not sure everyone does. But let's say I'm really depressed. I come in and see you, and you find out that I'm smoking pot every day. Are you going to treat me with TMS? And what's your advice going to be for me?
So, I don't have to hypothetically use you as a patient. I mean, these are real life patients who come to my office and sit in my chair. And I had a patient some time ago who was morbidly obese, which is a contributing factor to depression. I mean, that adipose tissue is inflammatory, causes inflammation in the brain. This worsens depression, makes treatment very difficult. She also was drinking almost all day long and smoking marijuana as close to 24 hours a day as she could manage. And so I said, the alcohol and the marijuana and the compulsive, food intake is the reasons that your treatment has been treatment resistant. And TMS is not going to correct that. I said, so let's talk about how to end those assaults on your brain. And then afterwards, if your depression isn't better, then we certainly can talk about TMS. And she was quite offended and said, I'm never going to stop drinking. I'm never going to stop eating. And I'm never going to stop smoking pot. That's why that's okay with me. But you also should plan on never not being depressed, because no medication, no amount of therapy, and no TMS or ECT is going to override the depression that's induced by the substance use. She said, I'll get TMS somewhere. And I said, you absolutely will. But it will not be here, because it would be unethical for me to sell you a service that I know is not going to work for you.
Tie that back in, because you talked about this some with the buprenorphine treatment, but just how, and maybe you want to tie in kind of the relationship based, maybe drawing on the social work roots or what psychiatrists used to do before 15-minute appointments became a thing. But the idea of how we help patients increase their recovery capital, whether it's for substance use treatment or mental health, just psychiatric treatment, but how medication is a tool, but that specifically what we're trying to do a lot of times is the behavior change outside of the prescription.
It's all, for me, it all goes back to the relationship with the patient. And it really dictates everything that I do at my job, that relationship. I was 19, I was severely depressed. It could have been from the alcohol, who knows? But I went to see a therapist, and I was very, very, very anxious. And this was a huge deal to me. And I debated I had all this shame about it. And, I didn't come from the land of mental health, and no one really believed in mental health and or getting help for it. And so this was a major, lifelong obstacle that I overcome for this monumental moment where I'm finally going to meet a professional in health, and he's going to help me not being depressed. And so that was my experience as a patient. I show up in his office. His office is kind of messy. He's got flip-flops on. He's got a t-shirt on. And then I sort of thought, oh, this is not that important, which is not the correct message to send. And so years later, looking back and reassessing that moment, it felt in some way disrespectful to me that this was a hard decision that I had made. And I want the person on the other side, the other chair, to also recognize how important this is. And so, I get a lot of flack for it, but I have always dressed very, very professionally as a way to convey my respect to the patient, and that this is a big moment and I'm here for it. I think medication alone does nothing. It does nothing. And I have never in my career, no matter what role I was playing, ever had a 15-minute appointment. If I have a 15-minute appointment with you, my only question is, everything's okay, right? Because otherwise I don't have time to deal with it. And even though I may have generated a lot of income for me or the people that I work for, I haven't really done a good job with a patient. And then the patient leaves feeling unattended to. And that's not what I want to convey. That's not the relationship that I want. And so we only, I mean, here at AIM, we only have a 30-minute or hour-long appointments for med providers. And I encourage like all the med providers to get to know the patient, and if the patient is going through a difficult time, extend that to an hour. The more that you know about the patient, and patients experience that this person is invested in my well-being. And I also like psychiatrically think of the medication as a little piece of Dr. Book, and every morning they sort of take that and remind themselves, I'm having this struggle. I'm dedicated to getting better. And the medication from a psychological standpoint, I think is very, very beneficial in that way. You hear people all the time say it worked for a little while and then it stopped working. Well, because there are two stages of treatment of like depression, the intervention and then the fix, right? The intervention is the medication, the TMS, the ECT, whatever they use. But then as the symptoms improve, and usually they will, then you got to capitalize on that improvement and make life changes. And so TMS, I mean, back in the 80s, all my social work, not all of them, but some of my social worker friends, I gave their patients crystals to wear to line their energy. And I don't know enough about it to have a very strong opinion about it, but it didn't seem scientifically rooted. Okay. That's my attempt at diplomacy. But so then when I first heard of magnets, I thought, great, now we're doing magnets. Because I guess I just like envisioned a refrigerator magnet, and so I was just like very wrong about that. It's highly scientifically proven. And so I did the fellowship in TMS. And then I spent some time running through being a patient. And so I had a day of TMS so that I could understand what it felt like to be a TMS patient. So that when I sat down with a patient, part of that relationship is to say, here's exactly what's going to happen. This is precisely how it's going to feel. Also, I believe that not only the relationship with the TMS, technician is important. The routine is very important, but I go in and sit with the patient once a week. Insurance companies generally will pay for the first MD visit and then the last MD visit, and I don't really care about that. The right thing to do is to go see the patient every week. And during that time that I meet with them weekly, I talk about these stage 2 changes that they need to make. Do you exercise? And of course, people who are depressed don't exercise. About the third or the fourth week, they feel just a little bit better. And I was like, I want you this week to commit to me that you're going to walk 10 minutes one time. And that any positive change concept, if we can find that place and start there and then grow. Let's talk about the toxicity in your life. Where's the relationships that you have that are, perpetuating your depression? What community of people are you on? And my famous question I ask patients, what did you do this week for fun? And people are stumped by that. What did you do for fun? Yeah. Life's short, have some fun. And when you're depressed, of course you can't. But then as you get a little better, you want to start introducing this concept of community and connection, and also, having fun and doing things that you enjoy. So I think our TMS, my TMS, or however you want to phrase it or name it, is different because we are more comprehensive in our approach to the patient. Not just with TMS, but I love TMS. It's so gratifying. I mean, I think that I wanted to learn about it because I felt like, it was another tool in the box. I got to make sure it's a real tool, right? And it turned out to be a very, very real tool. And I mean, we monitor patients' Hamilton Depression Inventory scores weekly, and we're showing like a 78 to 82% remission rate for major depression. So by the time that the 6 weeks of TMS treatment are over, that patients' Hamilton Depression Inventory scores are normal. So
That's awesome. Well, last question for this round of our podcasting, because you've got a lot more to share, but I'd just be curious, what advice would you give to a psychiatrist, maybe just finishing their residency or in residency, thinking maybe they want a career in substance use treatment, but just what advice do you have to new psychiatrists?
That's a great question, Tripp. And I come in contact with new psychiatrists, and I see them, and they have the DSM-5, and they're like a magnifying glass, and they want to get exactly the right diagnosis, and they've got to get the documentation right. They have like a computer in the room, and this is like a boomer thing, but I don't like that. Like I don't have my computer in with my patient. The most effective tool that you have for healing is the relationship that you have with that patient. And you really have to remind yourself of that privilege, that it is, people share with you the intimate details of their thoughts and their feelings and their struggling. People who have addiction, when you meet them for the first time, they are by definition having the worst moment of their life. And more than getting a form filled out or a box checked, that person needs to experience what it feels like for someone to be with you in that moment and that connection there. And so, I think to, young psychiatrists or to young addiction medicine, professionals, just be with the patient. If you listen, the patient will tell you everything you need to know. And that, I think, is healing for patients, for people to be with them there. And all the other stuff, what's the half-life of this medication, and what exact code do you need to put here? Do that later, right? But when the person's in the room, just be with that person. I fall in love with my patients, because everybody has this amazing story, and it's like such a privilege for people to share that story with you and to be part of that process and a tool in their toolbox to help them get to a different place. So I sort of stumbled onto this career because I needed a job, and I had some psychology degree from LSU, which absolutely meant nothing. And it just sort of happened that this was a place that I could get a job. And, on paper, man, it looks like a well thought out plan, but it was just a series of just doing the next right thing. And, this sort of got me to this place, and, which so far, and I'm not done yet, has been just an unthinkable career.
Well, Dr. Book, I appreciate you carving out a few minutes on Friday afternoon for us, and we'll do it again soon.
Great to see you again. See ya.
Thanks for listening to the Advaita Health Podcast. If you enjoyed today's conversation, please follow or subscribe wherever you listen to podcasts and share it with a friend or colleague. You can learn more about our work at advaita.health. That's ADVAITA.health, or www.aimwellbeing.com. Until next time, be well.